Transurethral microwave thermotherapy is an investigational procedure currently under evaluation at 5 centers in the United States. A flexible catheter with a microwave antenna is sonographically guided into the prostate, where the microwave energy shrinks the gland as a cooling system protects the urethral mucosa. Dr. Kevin Tomera, a urologist at the Mayo Clinic of Jacksonville, says the interim results of microwave thermotherapy suggest it may be an alternative to transurethral resections in 40% of cases.
The symptomatic improvement is about 80% overall. In other words, the average patient goes from severe symptoms to little or no symptoms. And it appears to be equivalent, at least in terms of symptomatic relief, to that attained after standard prostatectomy or standard surgery. The flow rates, or improvement in size of the stream, are not as big as after a transurethral resection of the prostate.
He says that the ideal candidate for this procedure is a patient with moderate symptoms.
A typical patient that I would treat would be a 60-year-old executive who is very physically active, but is finding that his urinary urgency is disrupting his work schedule, and as well as that his getting up at night 1 to 2 times is just disturbing his sleep schedule. The nice thing about transurethral microwave thermotherapy is in a single 1-hour office session that this patient will find that his nocturia will be reduced to either 0 or 1 time at night. So the patient obtains an improvement in his flow, he obtains a significant improvement in his symptoms, and yet he has preservation of his normal prostatic and sexual function.
The only contraindications for thermotherapy are metallic pelvic implants, pacemakers, and predominant middle lobes of the prostate. Dr. Tomera says the only complication associated with thermotherapy is acute urinary retention.
Patients, if they're able to urinate in the office immediately after the procedure, usually are out of the woods. However, about 1 out of 6 patients will find after the procedure that his urination is inadequate, in which case we place a catheter, and the patient removes the catheter himself in about 3 days, and usually it becomes progressively better now that the initial phase of swelling is over.
Dr. Berry says that we still need more data on the long-term efficacy of transurethral microwave thermotherapy.
Because the long-term effectiveness of thermotherapy, at least in my mind, hasn't been established, I don't think it should be used to treat patients with advanced BPH complications such as hydronephrosis, complications that are better treated with transurethral resection.
Dr. McConnell agrees.
True with many of the device types of therapy in BPH have not been well controlled, have not been randomized, and we don't know what component of the improvement that some of these patients are enjoying is in fact placebo effect. Just now, randomized clinical trials with thermotherapy are beginning around the world, and I would hold judgment on the technology until the results of those trials are available.
Results from the American Urological Association study regarding the best treatment strategies for BPH should be available within the next 5 years.
One of the problems in clinical research in BPH is that obviously measuring the degree to which different treatments improve symptoms is very important, particularly to patients.
To provide a basis for comparing these therapies, the AUA has developed a symptom scoring system. The questionnaire is designed to be completed by patients. They are asked 7 questions that quantitate nocturia, frequency, urgency, and decrease in urinary flow. This objectively measures patient symptoms prior to therapy and evaluates symptomatic improvement following treatment.
The evidence now is that the symptom score may be in fact more objective than some of these other tests that we have done in the past. Its test, retest reliability, and predictive value is in fact very good.
We'll be comparing the symptom score response in those different treatment arms to see which may be the optimal strategy for physicians to recommend to which groups of patients.
In that middle ground between not needing any treatment and requiring surgery, there's a large number of men who would be appropriate candidates for so-called alternate therapies. But there, the decision should be for the patient to decide which is the best therapy for him.
Fair to say that with the data available thus far, it looks like the effectiveness of these treatments is somewhere intermediate between watchful waiting and transurethral resection of the prostate in most cases.
While TURP remains the most definitive therapy for benign prostatic hyperplasia, new non-surgical treatments can provide symptomatic relief. If there are no obstructive symptoms or any evidence of prostate cancer, patients can be given the therapeutic options of watchful waiting, medication, or balloon dilation. For Internal Medicine Update, I'm Dr. Roger Bone.